CLL14 demonstrated improvement in progression-free survival, no difference in overall survival of venetoclax obinutuzumab versus chlorambucil obinutuzumab. Both oral agents were given for a year, and it was in a population with a high SEER score, which tended to be an older population. So one question I have and that people ask commonly is, are we willing to extrapolate that data into the younger, fitter patients? Is venetoclax obinutuzumab a regimen that we consider for those patients? I wonder if you could give us your thoughts on that.
Right, so even though the CLL14 is done on the relatively older patient population with comorbidity, but I think the efficacy from the venetoclax plus obinutuzumab combination is definitely quite striking and comparable to what we're seeing with the BTK inhibitors. And time-limited therapies are actually especially appealing for younger patients, those who would like to get started on a treatment but not to be on an indefinite treatment like a BTK inhibitor. So we have been, I think clinically, we have been definitely extrapolating that potential benefit in younger patients. And we have seen at least in the relapse setting, we have done trials that with venetoclax are showing benefit in patients with all age groups. So I don't think the age group would make a huge impact on the clinical benefit. And so another thing to consider when we're choosing BTK inhibitor versus venetoclax-based therapy is that whether a patient is willing to devote the time to have a very kind of time-intensive upfront therapy. So when I'm discussing with my patients, I'll say, you know, when you're choosing the venetoclax plus obinutuzumab combination, you almost have to devote weekly commitment to come in for almost 2 months. And you have to devote a certain amount of time in the clinic. And if you have good renal function, we can manage as an outpatient. If you know, disease burden is not a high risk. But if you're high risk for TLS, or if you have impaired renal function with relatively high disease burden, then we have to potentially admit you at least for the first 2 weeks of dose ramp up for venetoclax. So I think depends, we're choosing a treatment for the patient is also up to the patient's preference, whether they're willing to devote that upfront time to buy the time-limited therapy versus BTK inhibitors is relatively easy, doesn't really require too much of a time monitoring from the patient part. So I think each treatment has its own appeal.
Can I add the venetoclax obinutuzumab combination is going to be examined in a Cristallo study, which is comparing that combination with FCR in fit patients or BR in patients who might not be suitable for FCR. So I think that study is about to open, or it might have just opened, so it'll take a few years before that reads out.
And then there's the CLL13 study by the German group, which will also be looking at venetoclax versus chemoimmunotherapy. The only thing I would say in reference to, I recognize for the patients there's a lot more work. It's very onerous, the initiation of the therapy on the venetoclax obinutuzumab particularly. It's not an option that we have currently in Canada, but even just venetoclax on its own. But we need to remember, and this is what I tell the patients, is that ideally every patient is going to receive both agents at some point. And it's unlikely that the difficulty of coming into the clinic multiple times, the awkwardness of the intensity of the monitoring is going to get any better with a subsequent line of therapy. The patient's not going to get younger, fitter, or likely live any closer to the institution. So I usually remind them, if you are going to have to do this at some point, it's a matter of deferring it to the next line of therapy, or just, digging your heels in and starting now with the difficult one. And a lot of patients actually hadn't, nobody likes to think about the future, but ideally every patient will get both of the agents, right, at some point.